Good morning, everyone. Dr. Sham Biyani, MD, DNB, EDI, FRCA, and fellowship in regional anesthesia. Presently is an associate professor in All India Institute of Medical Science, Mangalagiri, Guntur, Andhra Pradesh. So his major achievements, he's been a faculty for RA UK, Cambridge, and Leicester UGRA CME workshops. I started take care of orthopedic surgery at Edinburgh Hospitals UK, and he is also the associate editor of JOACP and IA Forum and IJCA journals. He is a member of National Academy of Medical Sciences and Excellent Reviewer Award. He has received Excellent Reviewer Award from IJCA Journal 2021, and also has received Young Scientist Award for contribution in the field of medicine in 2021. And he holds the first prize for poster presentation at Rajasthan SZISACON 2011. He has 51 publications in national and international journals and has 4 chapters in textbook in his credit. Thank you, sir. Over to you.
For Biyani amputation, presumably on an emergency basis. Can I have my slides displayed, please? So I have put up a case scenario so that it helps us in further discussion. So say for instance we have an elderly old patient who is a chronic alcoholic and diabetic, who is not compliant with his medications and presents to ED with a diabetic foot ulcer, and there is an infection and the surgeons would like to take him up for a Biyani amputation. On examination you find moderate ascites and there are no other signs of any liver decompensation. Hemodynamically, he is slightly tachycardic and his blood pressure is slightly on the lower side. These are the investigations you get. I haven't put up the unit, sorry for that. The hemoglobin is slightly on the lower side. TLC count is slightly raised. Platelets are on low normal side. Both urea and creatinine are slightly de-raised. Total bilirubin is 1.8. Albumin is again slightly on the lower side. Fortunately, coagulation is still okay. As you can see, the blood sugar is not very well controlled, which is depicted by your HbA1c. Ketones and proteins were negative in the urine. So the question arises is, how would I approach in this case? So what would be my perioperative management? Starting with preoperative one, the first thing I would be interested is in taking a detailed history and examination of the patient. In the history, the first thing should come to my mind is what is the cause of chronic liver disease. Here it was alcoholic, but there can be non-alcoholic causes as well. Out of which it is the infections, either it is hepatitis B virus or C virus is the most common cause, but there can be other causes of CLD as well as depicted there. Coming to the second thing, I would be interested in knowing, are there any signs and symptoms? If in your clinical practice you get any patient who has got pallor erythema, swollen thyroid gland, spider nevi or anything, you should strongly suspect chronic liver disease as one of the possibilities. Okay. More important than that, what I am interested in is the patient is having any extrahepatic manifestations, because they are directly or indirectly going to affect my anesthetic plan and the further management. So this is the table I have taken up from British Journal of Anesthesiology, which pretty much summarizes what all the extrahepatic manifestations a patient with CLD can have. I have split it up into system-wise, taking the main important points. So coming to the respiratory system, patients may have decreased FRC, which is secondary to the pleural effusion, or it could be because of massive ascites, resulting in basal atelectasis and hypoxemia. The patient can also have hypoxemia because of the intra and extrapulmonary shunting, which is a part of your hepatopulmonary syndrome. The patient may also present with increase in your pulmonary artery pressure and pulmonary vascular resistance as a part of your pulmonary syndrome. These patients are also going to have a hyperdynamic circulation, and they are very prone to have hemodynamic instability during the induction of anesthesia, which could be because of underlying cirrhotic cardiomyopathy, or it could be because of diastolic dysfunction or decrease in systemic vascular resistance, which is a characteristic of patients with chronic liver disease. Coming to the GI system, patients with chronic liver disease are bound to have gastroparesis, so they are considered at higher risk of having aspiration, and it could be also because of the moderate ascites increasing in your intra-abdominal pressure. The patients may present with hematemesis, that means there is a esophageal varices, so you have to be careful with that, which is a part of a portal hypertension characterized by splenomegaly, massive ascites, and this one. And the ascites could be because of decrease in FRC, so that is the one thing. But that ascites can also result in increase in your intra-abdominal pressure, compromising the renal blood flow, resulting in acute renal failure, and predisposing these patients to have spontaneous bacterial peritonitis as well. There are other systems which are also affected. For example, central nervous system, there can be hepatic encephalopathy. Renal, as I said, they can have acute renal failure, which is mainly because of hepatorenal syndrome, but there can be a renal and post-renal causes as well. Hematological, this is the normal picture you get in patients with CLD. There will be anemia, thrombocytopenia, and coagulation abnormalities. These patients are at very high risk of having infection and impaired wound healing because of the malnutrition and the muscle wasting, which is normally seen in these patients. So once I'm done with the extrahepatic manifestations, the last thing I would like to be seeing is there any history of decompensation in that particular patient. So any patient who is presenting with a history of severe jaundice, severe coagulopathy, portal hypertension, massive ascites, renal dysfunction, or hepatic encephalopathy, should always consider that probably the patient is having a decompensation. Okay. The next thing, once I'm done with the history, I would like to know what is the severity of the chronic liver disease the patient is having. There are various scores defined in the literature, but the most commonly used one are the Percott classification, which has got 5 components, which is encephalopathy, ascites, bilirubin, albumin, and either the prothrombin time or increase in the INR ratio. So as you expect, there is a grading from 1 to 3 with a minimum score of 5 and the maximum you can expect is 15. Okay. So once you put up the values, you calculate the score and the patient may fall into category A, B, or C depending upon the total score. The importance of that is it will help you to know what is going to be the perioperative mortality rate depending upon to what class the patient belongs to. The second score which is used is called as the MELD score. The problem with your CPT score is that there are 2 components which are subjective in nature, the ascites and the encephalopathy one. But here MELD is a purely objective score where you get serum bilirubin, INR, and serum creatinine. And many of these online calculators, they ask for a serum sodium as well, which is a UK modification of your MELD score. Again, once you put up these values, you will get a data. So if I go back to my case where we discussed what are the investigations were, this patient would have a child class B because the total score was 17. If you put into the MELD score, you will get a score of 13. I'll come back to this a little later. As my patient is diabetic, I am also interested in knowing what is the effect of diabetic on individual organ systems and what is the glycemic control of this patient. Due to time limit, I am not going to go into the details of diabetes and its effect on all the organ systems. We know that similar to chronic liver disease, it is also a multi-organ system affecting every organ in your body. So the complications can be summarized as macrovascular, microvascular, or metabolic complications. But the major burden of diabetes is on your cardiovascular system, and the major cause of mortality even in diabetic patients is either coronary artery disease, silent myocardial infarction, and these patients are again at very high risk of having a hemodynamic instability because of the underlying autonomic neuropathy. And we all know patients who are diabetic on insulin, it is an independent risk factor according to your RCRI criteria. These patients may have difficult airway because of the glycosylation of the proteins, and similar to chronic liver disease, diabetic patients are also gastroparetic patients at increased risk of having gastroparesis and aspiration, impaired immunity, we all know that, and they are at increased risk of having thromboembolism as well. Though this table doesn't apply to me because my case is an emergency one, but I have put it up for just to put up a thought that these are the recent guidelines. The HbA1c value should be less than 8.5% if you are planning for an elective surgery. Though if it is more than 8.5%, it is not a contraindication, but that will tell you whether the patient is, how it will be easy or difficult to monitor the patient's glycemic control in the perioperative period. And the aim should be to monitor it between 100 to 180 milligrams per deciliter. Once I'm done with that, then the next thing is what surgery the patient is coming for. As my patient is coming for a Biyani amputation, there are a few concerns with this. So the most important thing is I would like to manage his perioperative pain so that to avoid phantom limb pain. The patient may have stump neuroma and needs a psychosocial support in the perioperative period. The last thing in my preoperative preparation would be to get few investigations done. Okay. So the first table is the investigations you would like to have for a patient suffering from chronic liver disease, and the second one is for your diabetic patients. As you can see in these tests, there are few tests which you can get done on a point of care basis, which includes your TEC, which includes your echocardiography, arterial blood gas analysis, and a urine analysis, forming a point of care testing, because the results of these tests will help you in a great extent to formulate your anesthetic plan and the further management. So the next important question arises is, do I have a window period to optimize this patient? The patient is posted for Biyani amputation, that doesn't mean that I have to rush to theatre. I have got maybe like 4 to 6 hours, 8 hours talking to the surgeon because I would like to optimize patient as much as possible before taking him up to theatre. So that depends upon what the patient's surgery is posted for and what is the patient's underlying condition is. In my case, I would like to assess his volume status because he was little tachycardic, little hypotensive. I would like to get a tech done to see if there are any coagulation abnormalities which I can correct pre-operatively, correct any metabolic and electrolyte imbalances based on your ABG value. And if the patient is having say massive ascites, massive pleural effusion, probably something I have to address that before taking the patient into the theatre. Similarly, for diabetic patients, we know that resuscitation is important because the patient may present with diabetic ketoacidosis and they will be hypovolemic. Would like to start that patient on insulin infusion in the perioperative period, again correct any metabolic and electrolyte imbalances. And we all know that infection is the most common cause which is tipping these patients into DKA, so you have to administer perioperative antibiotics. So once I am done with that, I would like to get a consultation, maybe from an hepatologist, a diabetologist, an intensive care unit person, reserve a bed in the HDU or ITU. I would like to avoid any sedative pre-medication in this patient. Remember that benzodiazepines predisposes the patients to have hepatic encephalopathy in CLD patients, and make sure that there is a blood available. So the next question arises is then what I am going to do. How would I approach in the intraoperative period? So this is again a table which applies for your elective surgeries. Depending upon the class, whether the patient falls into CTP A, B or C, or your MBLD score below 10, few textbooks say 10 to 20 and more than 20. You can proceed with surgery with caution. If it is CTP B, it is make sure that you optimize the patient and then take him into theatre. If it is a too severe one, probably you have to consider whether I can postpone the surgery and take it up on a later date. So what options do I have? I have a central neuroaxial blockade, just a peripheral nerve block, general anesthesia, or a combination of this, or I would like to just postpone the surgery. Let me make a very important statement here. When you look into the literature, there is no evidence to show that regional anesthesia is better over general anesthesia or vice versa in CLD patients. It all depends upon what the patient's underlying severity is and what the surgery the patient is posted for. If I am considering the regional anesthesia, I know that there is abnormal coagulation. Metabolism of your local anesthetics is going to be derailed because there is a CLD and there is decrease in protein. So the free levels of your local anesthetics in the plasma is going to be high. They are at higher risk of having local anesthetic systemic toxicity. Coming to the diabetics, yes, the onset will be faster, the duration will be prolonged because the nerves are having a compromised vascular blood supply. So this is called a second-date hypothesis or a double crush phenomena. And so you have to use low volume and low concentration in diabetic patients. So if you have opted for a central neuroaxial blockade, I would like to have a wide bore IV cannula, definitely put an arterial line. These days you have minimally invasive cardiac output monitors like FlowTrack or Vigilio. I would like to have that one. As I said, you have to be careful and do it under aseptic precautions and continue your insulin in the perioperative period. You can consider adjuvants on case-to-case basis. If I opt for a peripheral nerve block, the principles pretty much remain the same, except for the fact that I would not like to use any adrenaline as an adjuvant because there is a compromised blood flow to the nerves, and dexamethasone because the patient is severely uncontrolled diabetic. Again, as I said, low volume and concentration. If you are planning for any sedation, not to use benzodiazepines, dexmedetomidine you can use, but we all know that it undergoes metabolism in the liver, so you have to be careful with the dose and titration. General anesthesia, it is unavoidable a few times, so you have to give general anesthesia. Say for example, the surgery is not possible to be done under regional anesthesia, or there are any contraindications for regional anesthesia, including abnormal coagulation. Patient is in hepatic encephalopathy, has got massive ascites, already hypoxemic. In that case, probably you have to go for a general anesthesia. The important thing you need to remember is that it affects the pharmacokinetics and dynamics of majority of the drugs which you are going to use for your general anesthesia in terms of distribution, metabolism and elimination of these drugs. It also depends upon which drug you are talking about and whether it is dependent upon the hepatic blood flow or the intrinsic activity. In cases of cirrhosis, it is the intrinsic activity which is majorly affected and there will be decreased binding protein, so the free plasma levels of the drugs will be increased. If I plan for a general anesthesia, pretty much the principles remain the same, except that I would have a low threshold for putting a central line as well. Make sure that I have got some vasopressors and all the emergency medications readily available. So I would like to have a RSI because, as I said, these patients are at higher risk of having aspiration. I would like to use a slow and titrated induction because these patients are prone to have hemodynamic instability. We have discussed the causes. Opioids, it is found to have fentanyl and remifentanil safe to use because they either do not undergo metabolism in the liver or they do not result in any active products compared to morphine and pethidine, which are better to be avoided. Propofol has found to be an induction agent of choice even in patients with CLD. There is limited literature for me to comment on thiopentone, ketamine and atominet, but they all have been used. There is lots of literature comparing TIVA with inhalational anesthetic agents saying which one is better, but let me make it very clear that there is again no evidence to say that we should use TIVA or inhalational agents. You can choose what you're comfortable with, but when it comes to inhalational agents, desflurane is found to be the safest one, followed by isoflurane and sevoflurane. And understandably, you would like to use those drugs which do not undergo any metabolism in the liver, like atracurium and cisatracurium, as your muscle relaxants. No matter what you have chosen, whether it is regional anesthesia or general anesthesia, this is the most important slide of my presentation. What should be your intraoperative goals? The goal should be to maintain hepatic blood flow and hepatic oxygenation supply. You avoid using any hepatotoxic and nephrotoxic drugs. You avoid hypothermia, hypoglycemia, hypocalcemia in the intraoperative period. These patients may have delayed awakening because of the underlying hepatic encephalopathy. You get a dead tech done and then see what is the cause, and then you can correct your bleeding accordingly. Never ever stop your insulin infusion. You continue it throughout your perioperative period. We all know what is the rate we are going to use, so I'm not going to go through that. I already discussed what monitoring I would like to have, but on top of that, I would like to have a neuromuscular monitoring, temperature monitoring, urine output. Transesophageal echocardiography is a very good alternative, but be aware that if the patient is having a history of hematemesis and esophageal varices, you would not like to put that one. ABG and TEC have found to be very good intraoperative monitors so that you can monitor the intraoperative physiology of this patient. Coming to the postoperative period, it doesn't mean that once the patient is out of theatre, your responsibility ends there. These patients still can have hepatic and renal decompensation in the postoperative period, resulting in deranged coagulation, jaundice, ascites, varices, bleed, hepatic encephalopathy. And as a part of the diabetes, they can have hypoglycemia, diabetic ketoacidosis, surgical site infection, or thromboembolism. Pain management, as I already said, is an important concept because the patient is posted for below-knee amputation. There are various options, so you can use PCA in the form of fentanyl or remifentanil. Tramadol can be used, but in a lower doses and safely. The third thing is important. You always consider using non-opioid adjuvants in this patient because you would like to avoid morphine and cut down the use of opioids. Paracetamol can be used unless it is not a cause of chronic liver disease. The maximum dose recommended is 1 gram TDS. No NSAIDs, epidural and local. If you have put a catheter, you can definitely use that one. Sometimes, unfortunately, you have to postpone the surgery, taking the risk into calculation. So if the patient is in CPD class C, MBLD more than 20, severe hepatic encephalopathy, you would like to optimize these patients. So to summarize, it depends upon what surgery it is, what is the grade or severity of the chronic lung disease, what the extrahepatic manifestations have, and what algorithm we are going to follow. As my patient was posted for an emergency surgery, I would like to take a high-risk consent, reserve a bed in ICU, optimize my patient as much as possible, and proceed with caution. And my management plan depends upon what investigations I am getting and their results. So if I go back to my case scenario, 30 seconds I'm finishing. I would like to optimize it with fluid resuscitation, vasopressors if required, continue insulin, get some electrolytes and the blood investigations done, put an arterial line and a cardiac output monitor. I would like to go for a regional anesthesia with a peripheral nerve blockage and optimize the analgesia and look after this patient in the HDU. So the key points of my presentation are that patients with CLD are at increased risk of morbidity and mortality. So you assess the degree of liver dysfunction as the criteria we have discussed and optimize your patients as much as possible. Outcome is dictated by what is the underlying degree of the dysfunction and the type of the surgery patient is posted for. The main important goal is to maintain intraoperative blood flow and hepatic oxygen supply. Diabetes itself is an independent risk factor which affects morbidity and mortality. Never ever stop your insulin infusion in the perioperative period. Be wary that they can have diabetic ketoacidosis and hypoglycemia in the perioperative period. So I would like to thank the organizers for giving me this opportunity and wish you all a very happy Independence Day in advance. And I'm happy to take up the questions at the end if there are any. Thank you so much.